Ma'am, I sent messages in all IM groups.
Okay. मतलब मुझे तो कुछ एक्स्ट्रा मैसेज अभी आया नहीं है.
You are in the official group of IM, no? We have 8 groups.
Maybe you can send mail once as well. And I
Okay.
think we can start.
Okay.
Yeah, just tell me when. Should I
Yeah,
start?
sure. Ma'am, first we
Okay.
will just have a short introduction. Ashmita,
Okay.
please share the screen, please. So, good evening, everyone, and thank you for joining us on a Monday evening. And I'm sure you must be tired after finishing your OPDs and clinics. And thank you so much for joining us to listen to Professor Aparna, who is a professor at the Fixel Institute for Neurological Disorders in Florida. She has a lot of achievements and awards and accolades to her honor, and she is, I mean, perhaps the most down to earth and the most knowledgeable person about deep brain stimulation and other forms of neuromodulation in movement disorders, I should say. So the floor is all yours, ma'am. Please.
Thank you, Dr. Ela. Thank you to the other organizers and the organizing team. I so appreciate the kind introduction. Let me share the slides. Yeah. So, I work here at University of Florida, and I have been very fortunate to be a part of a very large DBS program. And we have taken care of several thousands of patients. And I have been here for a long time, so I have been involved in a lot of multiple aspects related to deep brain stimulation surgery. So I'm really grateful to my institute. Okay, yeah. So here are my disclosures, but I wanted to tell everyone that I'm not really receiving any specific financial support from any of the DBS companies. What I'm going to do is to start off with giving you an overview of DBS in Parkinson's disease in general, regardless of age, because the topic for today is older adults. So the first half I would spend on, what sort of patients go for DBS, what are the outcomes, what is the evidence, some of the programming techniques that we have, and a lot of new technological advances in this field. And the second half, I will specifically focus on DBS in older adults. What are the preoperative considerations, the perioperative or intraoperative, and what are the postoperative considerations? Parkinson's disease, it is the second most common age-related neurodegenerative disorder. So I know a lot of people in this audience are interested in the geriatric population. So the average age of onset is 60 years. And an estimated 7+ million people are suffering from Parkinson's disease. A large number of people in India also have Parkinson's disease, and the number will continue to grow as the aging population increases. The core phenotype of Parkinson's disease is that slowness or the bradykinesia, the poverty of akinesia, bradykinesia, the poverty of movement. And many individuals will have tremor, and you may have seen this in your clinical practice, the resting tremor, very classic pill rolling tremor. Some people also have the action tremor. They are slow, they have masked faces, they have lack of dexterity when they are performing their activities of daily living. Gait disturbance is also quite prominent. They start off with slow gaits, short shuffling gait, narrow base, but then some people also have this freezing, which you may have also seen in your clinical practice. But when do you really think about deep brain stimulation surgery? Deep brain stimulation surgery is definitely a very powerful, established, effective, efficacious, whatever words you want to use, but it is not really meant for everybody. So it's not like you get Parkinson's, that means you automatically go for DBS. DBS is usually considered, because at the end of the day, it's a brain surgery. So one should think about DBS if you're coming across patients who have medication refractory tremor, or people with motor fluctuations. As you can see, he has something called dyskinesia, levodopa-induced dyskinesia. So the oral pharmacological treatments for dyskinesias are not very impressive. There are some medications, but DBS definitely is very powerful. And another indication, the motor fluctuations word indicates means when people are taking levodopa, in the beginning, things are working out fine. They are able to get around with their day-to-day activities of daily living. But as the dosage goes up 5 times daily, not just one tablet, it could be 2 tablets, 3 tablets. So as the frequency keeps going up, basically why the frequency is increasing, because the medications are not really work the entire time. We call it connecting dose to dose. So people in the beginning may be taking 8 a.m. in the morning and 8 p.m. at bedtime, but then it becomes 7 a.m., 11 a.m., 4 p.m., 7 p.m. Then it becomes 7 a.m., 10 a.m., 2 p.m. So every 2 to 3 hours, if patients are taking medications, that's the time one should realize that the medications are not really giving that smooth control. And that's the time one thinks about DBS. As you can see, this particular picture illustrates that Parkinson's disease is not just 20 years is a rough estimate. Some people have Parkinson's disease for a longer duration, and some people succumb to it earlier to the disease for one or the other reason. But as you can see that as the disease progresses, the non-motor Parkinson's disease is not just a motor disease. There are a lot of non-motor issues, particularly the cognitive impairment, dementia, and in aging population, that of course is a big consideration. So as you can see, as the disease advances, probably DBS may not be a good idea. For the longest time, DBS was offered when patients were roughly 10 to 15 years into their disease. So somewhere, as you can see on this horizontal bar, somewhere here. But a large trial was conducted, and now several studies have reported their real world data. And it was found that DBS, when performed early, can actually improve the quality of life, and there's really no reason to wait till the disease has advanced significantly. However, don't try to offer DBS very early, because if the diagnosis is not very clear-cut, there are some other issues, then it is better to wait at least 5 to 6 years. From a milestone perspective, the functional neurosurgery was not really what it is today. Previously, open surgery was the way to go. We didn't even know where exactly the surgery should be, like which targets in the brain are really the areas which can help, if intervene, can help patients with Parkinson's. The discovery of targets was very serendipitous, because Parkinson's disease patients were developing strokes for one or the other reason, and we found that strokes in those locations led to improvement of the Parkinson's disease symptoms, and that's how we learned that those targets in the brain are the areas where if we do some intervention, we may be able to help our patients. Then, of course, there were some advancements of stereotactic apparatus. Then, of course, there was a little bit of hiatus because the discovery of levodopa. So there was a point of time when everybody was just focusing on levodopa, which was in late 60s and 70s. But then we recognized that levodopa is not the perfect therapy. It's a very good therapy, but in some patients, it starts showing the dyskinesia or motor fluctuations, or it may not help the tremor. And that's the time when, again, the surgical interests grew. And in late 80s, the DBS kind of took off. And now thousands and thousands of patients have gone through this surgery, can go through this surgery. So this is a review article that we published last year, which talks about the nuts and bolts for people who are new to this field, as to what sort of patients should go, what targets, what devices, and what programs should be followed. Patient selection consideration. Age is actually one of the important topic for today. There's no specific age cutoff, but of course, when people are, 65 to 75, it's okay. But if it is more than 75, you have to be very careful. It's not the chronological age, it's the biological age that matters. A very healthy 80-year-old can still be considered for DBS, but a 70-year-old or a 60-year-old with lots of comorbidities, one has to be careful. We oftentimes rely on this levodopa challenge test. Of course, it has its limitations, but in general, 30% drop is really needed because people who are not having 30% drop in the motor improvements, we measure it with a scale called UPDRS, are probably not even having Parkinson's disease. And if somebody demonstrates more than 50% improvement, it's quite possible that this patient is definitely going to do well with DBS. So features or symptoms of Parkinson's that really do well with levodopa tend to do better with DBS. So DBS is like a good booster to the levodopa therapy. It kind of shifts the clock almost 5 years back, except for tremor. In tremor, sometimes the levodopa is not effective from the very beginning. The timing I mentioned that you can consider as early as 4 years. Non-motor, one has to be mindful. If there are lots and lots of non-motor symptoms, some of them can improve, but if the patients are really bothered by the non-motor symptoms, then counseling is required. Axial symptoms may have improvements in the beginning, but as time goes by, the axial burden will continue to increase, and these features are not as responsive to DBS. The appendicular features will improve. But the axial features, one has to counsel appropriately. Then the genetic factors should be considered, comorbidities, and social support is super important. We all want to know what is the evidence for DBS, and we want to know whether there are really any randomized controlled trials to get that high quality evidence. So the famous story is about these 8 trials that were conducted over a period of 14 to 15 years, and they were moderately sized, as you can see the N that participated, and these were all positive trials. Some of them focused on the motor improvements captured with UPDRS, and some of them focused on quality of life, and the follow-up, as you can see, is quite variable. But they all demonstrated that DBS definitely was a powerful and an effective therapy. When we counsel our patients, what numbers to use, we can tell them that there would be roughly 40 to 50% improvement in the motor severity. The off time will go down, the dyskinesias will improve, quality of life would be roughly 30% better, because quality of life is not just about motor, there are a lot of non-motor issues as well. And one has to also counsel that maybe about 10% or maybe slightly higher may not benefit as much as they expected. Again, that's because of non-motor balance. One should counsel that DBS is not going to help with dementia. It's not a treatment for falls or dysphagia. Regarding the non-motor outcomes, so when people go for STN DBS, subthalamic nucleus, it has been found that it may lead to reduction of carbidopa-levodopa overall dosage. So that in itself can lead to improvement of impulse control disorder, which is related to excessive levodopa intake. It can STN DBS could also could improve sleep, pain, fatigue. There is not as much data with GPI DBS and non-motor outcomes. How does the patient selection process flow? The pre-screening, which is basically a conversation between the neurologist and patients and caregivers. A lot of you in the audience are probably at this stage or are a part of even screening and scheduling aspects of DBS workflow. It's very important to have that conversation with the patients and the families about setting goals and expectations. As I said, if the patient has dementia, please, one should not tell them that your dementia is going to get better after DBS. An ideal screening process, why do we need that? We want to know whether the benefits are far greater than the risks. So we have to do the risk-benefit analysis. We have to be able to gather data and provide patient education and finalization of candidacy. So what is the purpose of so many disciplines? That's because of like a 360 evaluation, because the patients should be seen by, of course, the neurosurgeon who is going to be doing the DBS, neurologist, but also the neuropsychologist, psychiatrist, and the rehab facilities, and if possible, social worker. And then, of course, the surgery gets scheduled once the consent has been obtained. Another slide for illustrating the workflow. Once the patients have been selected for DBS, the surgical team kind of takes charge as we get closer to the DBS date. Pre-op assessment, particularly, the anesthesia gets involved, the pre-op team gets involved. A high-quality MRI is performed before the DBS on the day of the lead implantation surgery. So DBS is about placing the leads in the right target. And then there is this extension cable, which gets connected to the IPG. In some centers, everything is done in the same day. At our center, we perform the lead. We just connect the extension cable and we schedule the IPG on a separate date. In some centers, both the leads are placed on the same day. We call it the simultaneous DBS implantation. At our center, we prefer to do, for Parkinson's disease, we prefer to do a stage process. A stage process means we place the lead one side, place the IPG, do the programming, optimize, and then evaluate again clinically, and then consider the other side. There are pros and cons for both the approaches. Regarding the brain targets, for Parkinson's disease, we have the subthalamic nucleus and we have the globus pallidus internus. At our center, we target both. There was a point of time when the thalamus, the VIM nucleus within the thalamus, was also considered, but VIM is very powerful for treating tremor, but it won't address the other features of Parkinson's, which is the bradykinesia, dyskinesias, or the motor fluctuations. On the day of the surgery, at our center, the patients come in the morning. On the day, a head ring is placed, a CT brain is performed, obtained. CT MRI co-registration is done on the planning station. The surgeon will plan the entry point for the lead, the trajectory, and the target, identification of the target. Then, of course, the burr hole is created. Microelectrode recording. So some places MER is not really done. Some places, like at our center, we do take MER, which is basically physiological recording. So up to this point, it was all radiology, but we also take help of physiology and try to integrate the two sources of information. Then, of course, the lead is placed, lead is confirmed. Testing, lead confirmation can be with simple X-ray, or it can even be an intra-op CT. Testing contacts in the operating room. So the neurology team is involved here. And then the patients get discharged home generally the next day, unless there is some issue or complication. Particularly in elderly people, we have to be mindful of that. And then we call the patient 4 weeks down the road for the battery placement. For battery placement, general anesthesia is needed. At our place, DBS lead is placed awake. In some places, a high-quality MRI is done, and it's called asleep DBS. So it's basically a purely radiology or MRI-guided DBS. Once the lead has been placed, the IPG has been placed and has been connected with the lead, the patient gets scheduled with the neurologist for programming. Programming, of course, you need a team. A single neurologist, it would really be very tiring to do the programming. The team could be a nurse practitioner with sometimes the company reps are also helpful. It's quite time consuming, particularly the old approach. The newer approach is supposed to shorten the time, and it does shorten the time in some individuals. So here is the list of the drawbacks of traditional programming, and here are all the new techniques that are now available, because the lead, which has contacts at 4 levels, the electrical field can now be steered. It can be axially, it could be vertically. Previously, it was just that one contact you find and you give that monopolar. Monopolar means the contact in the brain is cathode and the IPG acts as the anode. But now there are lots and lots of ways of delivering the electrical field. And there are so many technological advances, and I would be covering them in brief. When we are doing programming, it is very important to, again, revisit the patient issues. What is it that you have to know your patient? What does the patient want? What does the patient have? Is it the tremor? So based on that, you can actually focus on the programming, because with the electrical field and the settings that you find, you may not necessarily address everything, but then it is better to rank the list with the patient. Tell the patient, what do you want? I'll first focus on that and then try to achieve as much as possible. So patient communication and education are two important leads. When the patient comes to you in the clinic, the first goal is to make sure that the impedances are checked for hardware integrity. Lead measurements are also needed. So as I said, the lead is placed, IPG is placed, lead is connected. At our center, we like to do the CT scan roughly 4 weeks after the lead is placed, because when the lead is placed, there is a little bit of CSF that comes out. So there is a little bit of brain shift. So whatever we had actually targeted and maybe measured with the MER may not necessarily exactly perfectly match with where the lead is placed. So you have to account for those little errors. That's why we like to take the CT scan 4 weeks later, so that CT gets co-registered with the pre-op MRI, and there are a number of softwares available. We use Brain Lab at our center to assess where exactly whether the lead has been placed in the intended location. Keep in mind, when the lead is placed, there is always a micro lesion effect. That means it's like a honeymoon. Because of the edema, suddenly you'll see that the patients are remarkably better, the tremors are improved, and some of the movements are better. Sometimes even gait and speech is better. But that's kind of like a honeymoon. Because as the edema settles down, that's the time when you start seeing the true disease burden and the programming effects. When you compare Parkinson's disease with other movement disorders, as you can see, it takes roughly around 3 to 6 months for the programming benefits to emerge. At our center, we usually schedule the patients on a monthly basis for the first 6 months, and then every 6 months, or as and when needed. Like, it depends. Not everybody is going to be perfect at 6-month mark. If some people need a little bit more time, we accommodate for that and we offer more appointments. There are lots of aspects related to programming: what contact to pick, what parameters to choose, what configurations, and what patterns. Programming should be done off dopaminergic medications, because you really want to isolate what is the stimulation doing to the patient. But it's not just off med, on step. You also want to see the patient on med, because dyskinesias, which are often induced by levodopa, may not be captured when you're seeing the patients. Again, in my clinical experience, there is a lot. That's why you have to see patients on a multiple basis, repeated occasions, because what you learn about the patient in those 30 minutes or 60 minutes or maybe 90 minutes is not something that is happening with them at home. With regards to the features, usually rigidity is very quick to improve. Tremor is tricky because tremors are so fluctuating. Sometimes the patients look very calm to you, but actually the tremors are something that is emerging in certain situations. If there is a little bit of anxiety, tremors become very remarkable. So it is what you see in the clinic is not exactly what the patients are experiencing at their home or in their natural setting. And the tremors sometimes are not just resting that is bothering them. It could even be action tremor. So I oftentimes have tools in my clinic. If the patients report that I have tremor when I'm typing or texting or writing or eating, feeding, drinking, dressing. So I try to assess the patients when they are doing those tasks, how bad is the tremor, and how I can help them with the programming settings. As I said, choosing the right contact is important, and that's a very step-by-step, iterative process. It is time-consuming. The goal is to find that wherever the lead is placed in that brain target, as we know there are a number of contacts, to find the contact which has like a good wiggle room. That means a very low dose of current results in benefits, and a very high dose is needed for the side effects. Because keep in mind, these targets are surrounded by fibers. When stimulated, particularly the internal capsule, if stimulated, that can result in side effects. Here are the different configurations possible. And as you can see, with all the advancements, now we can fractionate the current vertically. We can horizontally direct the current. We can do a number of other, we can even give anodic stimulation, monopolar, double monopolar, bipolar. So as you can see, there are lots of possibilities that we can use for our patients. Sweet spot. So as I said, GPI is the target, STN is the target, but where in GPI? It's the postroventral location, which is found to be very effective for controlling bradykinesia and rigidity. And in the STN, it's the dorsolateral STN where the sweet spot has been found to be located. It's actually not even sweet spot, it's the sweet network. It's basically some of the fibers that are traversing this region and how they connect with other different brain regions. And if we are able to target that network with the electrical fields, that is what is resulting in all the clinical improvements. So it's not just about knowing your patient, it is also important to know the anatomy when you're programming. Nowadays, in certain DBS systems, you can even record the brain signals, and these brain signals could indicate whether the patients, these brain signals have been identified to correlate with bradykinesia, rigidity, tremor, dyskinesia, depending on the frequency peak. We call it the LFP guided or the sensing guided programming. The one form of DBS that got approved last year is the adaptive DBS. So what is adaptive DBS? As I said, you can listen to the brain signals. You can identify the peaks that correlate, particularly with bradykinesia and rigidity. That is very helpful. And if you identify that, you can actually tailor the stimulation to control those signals. So there is a little bit of automatic sort of programming. It's like an adaptive cruise control when we are driving. And of course, adaptive DBS did not happen in one day. It took a long time, over a decade, lots and lots of studies that got pooled in. There was more data. And the goal is not to overstimulate. Of course, the battery can be conserved if you don't give too much stimulation. But now the battery that is placed are of two types. One is non-rechargeable and the other is rechargeable. Non-rechargeable will usually last about 3 to 5 years. That means every 3 to 5 years, the patients have to be subjected to general anesthesia and you place the battery again. And rechargeable is like it has a much longer lifespan and you just have to recharge that battery. It could be once a week, it could be every few days, or it could even be once every 10 to 15 days. So because of all these research studies, the adaptive DBS, ADAPT-PD trial was conducted, and that was found to be a positive trial. That means adaptive DBS could be implemented in the clinical setting, and FDA gave the approval. Another advancement is image-guided programming, which is basically the MRI that was done before the surgery. You can actually employ it, it's called the patient-specific segmentation. You can identify the exact location of the lead in that specific nucleus that was targeted. And you can then, with that imaging evidence, you can deliver, because as I told you, it was very time consuming and lots of iterations. Is it the bottommost contact or topmost contact? Because you don't really know, even though you wanted the lead to be in a certain way, but you don't know exactly in that patient how the lead is positioned. So it's a good idea to have this extra piece of image guided programming that would definitely reduce the time for programming. Remote programming is also possible. Remotely, of course, the patients, when they have the patient programmer, they can always look for the battery status check or impedance check. But then with some systems, you can actually sit in your office and control the stimulation settings. So that is definitely a advancement, particularly people who are living in remote areas, mobility issues, they cannot come to your clinic frequently. Now moving on to DBS in older adults with PD. As I said, usually average age of onset for Parkinson's is 60. Young old is like 65 to 75, and I think up to 70, 75, a lot of centers have been doing DBS. The question comes up as to 75 to 85, what do we need to do? Should we offer them DBS? How about more than 85? Should we offer them DBS? So there are some preoperative considerations, perioperative, and postoperative. What are the preoperative considerations? What should we counsel them? Is DBS really going to be helpful to them? Should DBS be unilateral, bilateral? Like, should we just target their dominant side? Or should we just go for bilateral? As I said, some centers, they want to do, their approach is to do bilateral simultaneous. How about if the patients are very frail? How are the patients have some joint issues, musculoskeletal? Should we, and gait problems, should we really offer them some sort of a prehab? That means physical therapy, occupational therapy. These sort of helps are provided way before the actual DBS surgery. How about the patients if they are on antiplatelets and anticoagulant agents? So regarding the motor outcomes, if you remember, I had presented this slide. These are the 8 randomized controlled trials. I looked at the age cutoffs that was observed, followed in these studies. And as you can see, some specifically said less than 75, some did not have any age limit, and they had roughly 30 patients, more than, of course, it was just a handful who were more than 70 years old. And some of them, as you can see, they were all around 60. Some of them were even 50s. So it's not like we have a lot of studies that have looked at motor outcomes when the age is more than 75. This study that got published recently, they specifically looked at people who were over 75 years old, and they divided the patients with disease that was 10 years, like a early on. Let me give you a case scenario. An 80-year-old comes to your clinic. His Parkinson's disease started when he was 60 years old, or there was another 80-year-old, his Parkinson's started when he was 70 years old. So what they found is that the motor improvements or even the complications were not significantly different, but people with longer disease tended to have lesser quality of life improvement, which is a little bit intuitive because as the age advances, there are a lot of comorbidities that come in. So the quality of life, as I mentioned, is not just about motor improvement. There are a lot of non-motor domains that go into determination of quality of life. So that could be impacting the quality of life. As I mentioned about the staging, should we go for one side or two sides? The advantage of bilateral is, think about somebody who is like 60 years old and he's relatively healthy. And as I said, some centers, they do go for bilateral simultaneous. That's because in one hospitalization, one anesthesia, anesthesia is basically light sedation. You can probably offer both the therapies. And I agree that the advantage is that Parkinson's disease is a bilateral disease. But keep in mind, does every patient need bilateral leads? That means there is more hardware. When you go for bilateral DBS surgery, each surgery is roughly 4 to 5 hours in duration, 2 hours. When I go to the OR, 2 hours of my own time and then 1 hour on each side. That means the surgeons are planning, the head ring, the CT scan, and then 1 hour for the closure of the wound. So 4 hours of that, add another lead, another 3 hours, maybe, if not 4 hours. So the longer the surgical time, higher the surgical risk, higher the issues. There are also issues with the CSF coming out, the brain shift. So the targeting can also be impacted if you go for 2 leads on the same day. So in older population, can they really handle 2 leads in one day? Preoperative considerations, The frailty index at our center, the surgeons are looking at this modified 5-item. Do they have diabetes, COPD, congestive heart failure, hypertension, whether they are functionally independent? What if they are on antiplatelets and anticoagulants? This is like a rough guideline as to when to discontinue and when to restart. Of course, it can also be individual based. You don't have to follow this like a blanket rule. Warfarin, usually heparin bridge is followed. Some of the newer direct oral anticoagulants, we tend to discontinue 3 days. First 24 hours after the DBS, we don't provide any anticoagulants or antiplatelets. What are the perioperative considerations? Targeting. That could be difficult because of the brain atrophy. I will discuss that in a minute. Patient tolerance. Keep in mind, it's like a lawn chair with this head ring. Could they really tolerate that position? Keep that in mind. How about anesthesia? Usually we like to do awake DBS, light sedation, sometimes if the patients are very anxious. But people who are doing MRI guided asleep DBS, general anesthesia is followed. And when we are going for the IPG placement, general anesthesia is employed. How about CSF leak and brain shift in older individuals because there is brain atrophy? A high quality MRI, as I mentioned. So this is the GPI target, F-Gator sequence, and STN target. As you can see, this green dot. I don't know if my cursor is moving right here. This is how, so keep in mind, we need to have these sort of high quality sequences for an accurate and a precise targeting of GPI and STN. Those are the two important targets. But coming to the older population, brain atrophy targeting could be an issue. Usually targeting is to be done through gyrus because in sulcus, there are all these en passant blood vessels. You want to avoid that. If the ventricles are large, if you are going to traverse or go very close to the ventricles, the chances of delirium or confusion could be higher. CSF egress could be a little higher in people with brain atrophy. And then the brain atrophy continues. So as I mentioned that we like to find the electrical fields, which is done maybe a year after DBS, but that 78 years old, now he's 88. Is that patient going to need the exact same stimulation settings? That is something to be kept in mind. Maybe the stimulation settings could change. Brain shift, here is an example. So why does the brain shift? The CSF goes out, air can come in, and there could be a little bit of shift. So the shift, of course, does not necessarily happen very uniformly. Greatest shift can be seen in frontal lobe, followed by temporal and occipital lobes, and the shift can range from 0.1 to 10 millimeters throughout all structures in the brain. So the point I'm trying to say is that if we plan for 2 leads, 1 lead, the second lead, if it is planned that afternoon, keep in mind that the targeting may not be very accurate. So one has to keep in mind that shift is a true possibility. How about if the patients are very anxious, they need to be provided anesthesia. Propofol can in fact affect the micro electrode recordings. So this was one study that was published recently, and they found that deeper levels, so light sedation is okay, deep sedation could be an issue. I mentioned to you about the rechargeable batteries. Could the older adults manage the device and adhere to a regular recharging schedule? So you have 2 problems. One is, can we go for non-rechargeable? But if it is non-rechargeable, then every 3 to 5 years, you have to go for another surgery to replace the battery. Then how about if we go for rechargeable and avoid that requirement? If we go for rechargeable, of course, there are advantages, but then we need to have a good caregiver team, a family support who can truly provide that support of recharging this device. So there are pros and cons of going for non-rechargeable versus the rechargeable. DBS in older adults. So let's look at what are the post-operative considerations. Some of the surgical complications like post-operative delirium, intracerebral hemorrhage, venous infarct, seizures, perilead edema, infection. Some of the stimulation-induced complications like cognitive decline, gait decline, speech decline, and the hardware-related complications, lead fracture, lead migration, IPG malfunction, hardware erosion, bowstringing, and Twiddler's syndrome. So cognitive decline associated with anesthesia. This was published in JAMA. Age more than 65. So as we get older, the risk of delirium is going to be higher. And some of the long-term cognitive decline can also be, the risk of that could also be higher in older population. Neuroinflammation as a result of perioperative stress, vascular disorder, acceleration of degeneration. The study that was published recently, what they found is that older age and baseline cognitive status was were the two critical risk factors for post-operative cognitive decline. The cognitive decline, if you look at from the different domains, what all could get better, what all could worsen. Cognition can worsen, apathy can worsen, executive function, language. In Parkinson's disease, it's mostly the processing speed, the executive function, the attention, the concentration. Those aspects tend to be more affected. Fluency can be affected as opposed to Alzheimer's, where it is the memory that tends to worsen. Gait and balance. Longer you follow, you're going to observe that posture and balance will consistently decline. As far as the gait outcomes, they're more heterogeneous. In the beginning, you may see some gait improvements. As I said, levodopa responsive gait will also improve with DBS, but then as time goes by, gait and falls will eventually emerge. But having presented all these considerations, one also has to keep in mind about the biological age and not the chronological age, and also the quality of life. You don't want the patients to suffer, even if you know that it's just going to be maybe for 5 years, but you have to do the appropriate patient counseling. Intracerebral hemorrhage, the usual asymptomatic is 3%, symptomatic is 1%, venous infarct, perilead edema, and some of the other post-operative complications. Perilead edema, it's the edematous reaction around the DBS electrode. Usually it is transient. I have seen some patients, but it is possible that that can lead to post-operative confusion. And in one study, the older people tended to have a higher risk of perilead edema. More MER tracks is also accompanied by increased risk of perilead edema. Skin erosions, as you can see, this is basically it's a hardware, and that hardware and the skin and the various reaction, the risk is not that high, it's 1 to 5%. This is an example of scalp erosion without infection. This is a more severe erosion. As you can see, you can literally see the battery, IPG. Infection is actually the most common. Usually it tends to happen early on, but sometimes it can even be delayed. If you have to identify the infection early, because you don't want the infection to spread from here to the extension wire to the DBS lead ultimately because of the brain abscess, meningitis. You don't want those type of complications. Occasionally, the infection can actually start in the scalp and go directly to the lead. So it's when to remove as one of the most common complication. Infections, as illustrated in this paper, it affected 5% of their population. And what all could be done. As you can see, there are a number of possibilities, prophylactic antibiotics, or there is that antibiotic envelope, what sort of pocket should be created, how frequent monitoring should be done, so where the IPG should be placed. So there are a number of aspects related to infection as a topic, and it was very nicely covered in this review paper. Lead fracture, it's a hardware. This picture will illustrate that. Lead migration. It can be ventral or it can be dorsal. So lead migration is another complication. And bowstringing. So it's what happens is this is the hardware. Scar tissue will form around the extension wire running down in the neck. So bowstringing, patients will complain to you about this tension and pulling and tightness. And that's because of the scar tissue that is formed. Twiddler syndrome. Twiddler syndrome, it's the patients will unconsciously keep rotating the battery or the IPG because it makes them feel uncomfortable. There is a possibility frail older people may tend to do it more, and maybe they are cognitively challenged, so they may keep moving and keep rotating the IPG. So one has to be mindful of that potential complication. How could you really determine? It's basically when the patients come to your clinic. I mean, if the DBS suddenly stops working, you have to wonder what's going on. Or more frequently is when they come to your clinic and you try to interrogate the DBS and you find that you're not able to connect with the IPG. And sometimes this problem also happens because of the subcutaneous pocket. There could be some seroma that develops, and because of that, that leads to irritation and rotation. So this picture is actually one of my own patients who had the Twiddler syndrome, and you can see that the wires are all twisted because the patient was uncomfortable. Sometimes the surgeons like to then place the IPG below the pectoralis muscle and not really subcutaneous so that that irritation component is lessened. But then it should, if it is a rechargeable one, then, if it is below the pectoralis muscle, then, recharging could be an issue. So you have to balance that. And of course, you have to replace the battery, untangle the wires, and and tack the IPG to the wall with a non-absorbable suture, and of course, counsel the patients to not engage in that rotation maneuver. And with this, I would like to stop this presentation and thank everyone. And these are some of my students and some of my funding agencies. I really appreciate I appreciate my institute and my team and my co-workers or colleagues and collaborators who over the years have really helped me in taking care of patients with DBS, Parkinson's disease patients with DBS.
Thank you. Thank you so much, ma'am. It was an elaborate discussion and very pertinent points regarding the applicability of DBS to older adults has been discussed. So we have a few questions in the chat. Dr. Hetal wants to know if one clinical assessment is enough to decide whether the patient is an ideal candidate.
Probably not. Because see, when the patients come to you, you are definitely going to do some medication adjustments and try to see with some pharmacological treatments, you're able to help them. Then you also have to assess the patient's levodopa off, like as I mentioned to you about the 30% improvement. It's quite likely that the patients may come to you for with an on-medication state. So you don't really know how much the patients really respond to carbidopa, levodopa. Now, if the patient is coming to you from another state or another place where the patients were seen by neurologists, and you kind of and you have good records and you have a good sense that, yeah, I mean, the tremors, they're becoming increasingly bothersome, and, it has not done with levodopa therapy, then maybe that one assessment could be enough. How will you adjust if a patient had beta, gamma by adaptive DBS? Yeah, so in the interest of time, I didn't really cover adaptive DBS in depth. A few months ago, I had the opportunity of coming and visiting AIMS, and I gave a talk on adaptive DBS. So again, adaptive DBS is not really possible in everyone, but if you can find that reliable beta signal, just to give you in short, it has not to be I mentioned to you that the patient gets a DBS, a month later comes to you for programming. First, identify the contact, identify the stimulation settings, identify the continuous DBS parameters, and then switch them over to adaptive DBS. And for that, there are different steps. I know I did not have slides for that, but you do the survey, you identify a contact where you can see a good beta signal, and in the clinic itself, you can do a little experiment of giving the electrical field and see whether you can control the beta, and that controlling beta actually correlates with the patient's bradykinesia improvement. Then it makes sense. Just controlling the beta is not enough. Once you identify that, then you kind of record the signal, like you send them home on, for a home monitoring, and then, you call them back again. So it roughly takes another 2 to 3 clinical visits before you can switch them from continuous to adaptive DBS, because you need to identify that reliable beta signal, which can be suppressed, that results in clinical improvements.
Thank you, ma'am. So I had a question that my residents often ask, and it is slightly a nuanced question, like especially during the selection process for DBS. So especially in older adults where there is a little bit of troublesome dyskinesia, and you started amantadine, there is a bit of fluctuations, and you are sort of trying to tide it over by giving some entacapone or maybe adding some. We generally tend to avoid dopamine agonists, but in the Indian setting, often because of financial constraints, we tend to sometimes try to tide over by adding these medications. And at that point, there is this tipping point where the patient starts having some cognitive issues, hallucinations. But you also know that when the drugs are withdrawn, maybe the cognition is not as bad and these hallucinations are drug induced. So it is a difficult conversation for us with the patients, caregivers as well, because we are going to give such a costly intervention, and the residents themselves are also not very convinced, because sometimes you tend to sort of look for contraindications to just exclude the patient out of the uh, DBS eligibility. So how do you deal with this, and how exactly do you take that call?
So, of course, I know I'm aware about the DBS costs, which I'm anticipating that over the next few years, 5 years or so, hopefully the costs will get better controlled. That can definitely be challenging. But if this patient was in a setting where cost was not an issue, let's just talk from a scientific perspective. In that case, I can see, I completely agree. I've also gone through similar experience. Take away the amantadine, take away the dopamine agonist, the hallucination part will definitely go away. Assess the patients once all the confounders are out of the system and see whether the cognition, how is the patient really doing? If the baseline cognitive status is not that bad, and not every dyskinesia needs to go for DBS. It has to be bothersome dyskinesias. It really has to be very interfering with their general functioning. And you all have seen some patients jumping out of the sofa or chair. That, of course, you don't want to really wait. So if the dyskinesias are really bad, cognitive burden is not that bad after all the confounders are out of the system, I would definitely offer DBS, and I'll go for GPI DBS. Now, dyskinesia is one area where, particularly in older adults, usually we want bilateral, because if it is an axial dyskinesia, one side DBS is not really going to make a big difference. In fact, a couple of weeks ago, I had this patient who had this lower limb dyskinesia and said he was very happy with the unilateral GPI DBS he had, but now he was actually thinking about contralateral side, because he had some cognitive issue after the DBS. So dyskinesia is a little tricky in that regard, particularly in the context of older population. Can they handle bilateral DBS? But I think older adults, if there are not too many comorbidities, unilateral DBS is definitely a possibility. At our institute, from an essential tremor perspective, like now I have taken care of a number of patients who have essential tremor, not necessarily Parkinson's, who are actually 90 years old. And they went for DBS when they were 89 and 90, which is like, oh my God, like they're really old. But that's because it is essential tremor. They went for unilateral DBS.
Yeah,
Another
unilateral
question that
DBS is something that we don't often offer here in India. That is something.
why?
I mean, most of the patients they don't sort of choose DBS early in the illness, and when they are like 5, 7 years into the disease, most of them have bilateral symptoms. And uh, honestly speaking, I have not seen a single case of unilateral DBS done at AIMS at least. I'm not sure about the other settings, but in our institute, there are no cases of
I
unilateral.
I see. At our institute, as I told you, we do staged, and a lot of them they end up with unilateral DBS and they're happy. Because bilateral DBS, I mean, unilateral DBS itself, I mean, DBS is a wonderful treatment, but it has its risks. I spoke about the cognitive decline. That is a problem. And I know GPI is considered to be relatively safer, but I've also seen post GPI cognitive change. So I think it may be instead of not doing anything, I think unilateral might be a good solution. Bilateral, again, the risk of delirium is higher. There are a couple of more questions. When
Yeah.
anode stimulation is used, anodic stimulation is possible only with uh, Boston Scientific, and I want to, every institute is different. I usually have more patients. I'm able to take care of patients with Medtronic system and not necessarily Boston Scientific. There are a few studies that were published from Germany using anodic stimulation. Um, I think it is just meant for, like I didn't really go into the configurations because this talk was not related to the DBS programming, but interleaving, cycling, and in that somebody also throws an anodic for some complex and challenging clinical features. Are there predictors to select continuous phospholevodopa? Uh, I mean, one versus the other, I'm assuming what you're saying. We actually have some people who are now having DBS and VLF pump or phospholevodopa. That is a possibility. So whether one should really go for phospholevodopa versus phospholevodopa is not really a great. I know it says continuous stimulation, less likelihood of dyskinesias, but if somebody has those bad dyskinesias, DBS definitely does a better job. Tremors. If there is a lot of tremor, patient, like again, phospholevodopa may not be able to control the tremors. But phospholevodopa, I think if that ups and downs that I spoke about, the motor fluctuations, I think phospholevodopa definitely can do a good job there.
And ma'am, what is your experience with one side STN and other side GPA DBS?
Um, So the medication burden can be an issue because on one hand, SDN, I mean, we have had situations where, at one, SDN was targeted for maybe the tremor, like one side the body had a lot of tremor, so they went for left STN. But then, as time went by, dyskinesia became an issue or dystonia became an issue. So tremor on one side and dystonia on the other side. So you go for GPI on the other side. I think that medication adjustment could be a problem. One has to be mindful about the anatomy, what you're programming, what target. On one side, on GPI, you go very ventral, and STN, you go very dorsal. So one has to be mindful of that anatomy as well. But that is a possibility.
And we have one more question, TBS versus focused ultrasound.
So in the context of Parkinson's, I know a lot of studies are coming out. At our center, we do offer focused ultrasound, but that is only for essential tremor. For Parkinson's disease in the subthalamic nucleus, to create a to create a lesion, because focused ultrasound is like, it's like a thermal lesioning, you're really, I think we need long-term data. I think DBS in the context of Parkinson's, I would rate DBS higher. When it is essential tremor, I know that focus ultrasound is a great possibility or a great option.
And I'm sorry, we are going just back and forth. The the people, geriatric neurologists, are sort of want to know more about the medical management and how rapidly do you take off medications after surgery? Like someone who has been on a very high dose of levodopa equivalent, 1500 or more, they are on entacapone and uh, agonist. So how do you take off those medications post-operatively?
So that's why serial assessments are important. That continuity of care is important. Um, as the patients say, "Oh, I'm a lot better. I'm a lot better compared to before DBS," then you slowly start, like whether you should do it 3 months after surgery, 4 months, 5 months, 6 months. That's a little bit like a relative call, depending on how the patients are improving. So as the DBS settings get determined and adjusted, then slowly you start reducing. Keep in mind, I mean, I think what Dr. Ela is presenting is like really heavy doses. Of course, that needs to be brought down. But if people were on moderate doses, it's not necessary that I mean, you may have read in literature there is a 50% drop and 80% drop. Some people, they need help from both levodopa as well as DBS. Particularly in GPI DBS, I don't see any reduction of doses. But even in STN, there are I mean, those who were on some every 2 hours and 3 hours, definitely we see that there is a drop. But people who were on maybe every 5 to 6 hours to begin with, I don't necessarily see that the medication dose also comes down. This is my clinical experience.
So, when do you take off the entacapone, ma'am?
So
That is also after 3 months.
yes, I would recommend to start thinking about medication reduction somewhere 3 to 4 months after, and the patients have to tell you that they are getting better. It's not even the patient, even the family. You may have come across in the clinic where the patients are feeling something and the wife is, not agreeing, or vice versa. Wife says there is an improvement and patients think. So, overall, there is a general agreement that there is an improvement. DBS is working, so we are on the right track. Then you can slowly start taking off.
Yeah,
And you
we
can ask,
something.
I oftentimes tell the patients that, try it. If it doesn't work, go back. Then we can reapproach it a couple of months down the road.
That is something again that is seen unique for our population. People, as soon as the surgery is done, they want to just get rid of the medications and reduce the pill burden. It's something from their perspective. They may be feeling that it is a good idea, but we end up in sometimes catastrophic because of this rapid tapering.
Right.
Thank
Sorry.
you. Thank you so much, ma'am. And I don't think there are any more questions. And I really thank you from the bottom of my heart for taking out the time from your busy schedule early on a Monday before your clinic. I'm sure you must be having a busy day lined up. So,
Yeah, I
uh,
also thank you and the audience. As you said, it's a Monday. Monday is not a good day in general because the whole week is lying ahead. So yeah, thank you again.
thank you. Thank you so much, ma'am. Bye bye. And thank you,
Bye.
digital team.